how does it feel to have COVID-19?
It was as if somebody had taken a scuba diving tank while I'm underwater and turned it off completely.
I was immobile, even detached. I couldn't move my head. I looked out of the corner of my eye and I saw people falling. I didn't know if it was real or not.
People were saying when I came in, I was blue. I remember perfectly well that I looked at my face and I looked like a Smurf. So I got scared.
I've seen death and I wished for it.
They were lucky to survive. The global tally of coronavirus deaths has already passed the mark of 120,000. In hospitals everywhere, medical staff give their all towards slowing the rise.
I'm seeing young patients, old patients, people of all age ranges who are just incredibly sick. And you can even hear it now that as I'm walking through patient rooms in the hallway, you just hear oxygen.
The virus has not been selective with its targets, and each case is its own story. So what exactly happens in the body during COVID-19? And are there any long-term health effects? These are some of the questions on which we're going to focus on this edition of COVID-19 Special. I'm Chris Kober in Berlin. It is good to have you with us. Now, high fever, a dry cough, and difficulty breathing. Those are the most common symptoms of COVID-19. Some people show mild signs of the disease, other more severe ones. So let's take a look at how long a person actually stays sick after contracting the virus. If they caught the virus on day 1, they will probably be contagious starting on day 2 or 3. And this lasts for about 2 weeks. Symptoms might start a little later and might even be present when people are not contagious anymore. On average, some 14% of patients with symptoms have to be admitted to hospital for up to 20 days. And half of these hospitalized patients, on average, end up in an intensive care unit. Now, for more, let's bring in Professor Klaus Rabe. He's a pulmonary doctor and former president of the German Respiratory Society. It's good to have you on the program. How does COVID-19 differ from other respiratory diseases, and what does it mean to the people treating patients?
First of all, good afternoon. Thank you for having me. This is a relevant question that's been asked to doctors like me all the time. Listen, there are commonalities and there are differences. Commonalities are this is a virus infection. And it means that you get symptoms such as cough, such as dyspnea in some patients, some mild symptoms, as you described in the program. There are some differences, however, and that is what we've learned. We've learned that people may have symptoms for a few days, and at day 6, 7, 8, they become severe. They develop dyspnea. They develop sort of a fatigue syndrome. They develop aches. And that makes sometimes the oxygen fall. It makes these people to present with more severe diseases, and this is when they need intensive care treatment.
What is the biggest problem with people that need this intensive care treatment?
Well, there are 2 things, obviously. You need the capacity to host them, to treat them in hospitals. And we've seen the reports from around the world. Shortages of intensive care beds has been a major shortfall in this discussion. In systems like ours in Germany at present, where we have enough capacity that seems manageable, although it takes a lot of toll from the nurses and the doctors and the intensive care units. But immediate care in intensive care with oxygen supply, with the delivery of proper care, including ventilation, is something which is needed then, especially since we know we have no real treatment available other than symptomatic treatment in the acutely severe individual.
Right. And patients that end up in intensive care usually need to be ventilated. At which point do you decide to do that?
Well, there are rules that are not COVID-specific, if you want. If someone develops this form of pneumonia, which starts with an interstitial pneumonia, as we say it, in the CT scan, it's detectable. These people drop with the oxygen tension. These people get severely dyspnoic. And when we measure an oxygen tension below a certain level, that's the time when we realize that there's a fatigue of respiration, that people need that sort of support. These people are then put on a ventilator in intensive care. Some people will be bridged maybe with non-invasive ventilation to avoid mechanical ventilation, but a lot of people end then in mechanical ventilation, and this is when they end up in ICU. This is another point that is making it different. We learned with time that the duration of ventilation in these individuals is longer than we anticipated, and it takes quite a few days until it's decided which turn they take.
Okay, and what does it mean being ventilated for the patients themselves?
It means that you're not conscious. It means that you are deeply sedated in an awake coma. That's what it's sometimes reported as. You will be intubated with a tube, and the airway system will be cannulated, and you will be ventilated by a machine with a certain oxygen delivery and a certain pressure to take over the mechanical need of breathing at the time when you're not capable of saturating your body with oxygen. It's an extreme situation. It takes a lot of toll, and it is a severe state. And you know from the figures that a lot of people, unfortunately, die under these conditions.
Can you tell us anything about the possible long-term impacts? Do patients' lungs fully recover once the infection is over?
Well, I think that's a very relevant question, and we've been asked this by many people, obviously. The syndrome or the symptoms or the disease is called ARDS, and people probably have seen this and heard this, acute respiratory distress syndrome. It means that there is chaos, if you want, in the lung. There's leakiness of the vessels and or the membranes in the lung. There's a lot of inflammation going on. We know from the literature from ARDS that a lot of people will have follow-up problems with their lungs. They scar. They will develop some sort of what we call fibrosis. These things may last for quite a long time once you survive them. So the research is now addressing this already, the long-term consequences of the lung disease, but also other diseases. The heart is one of the organ system that will also be affected. So we would expect that once people survive intensive care and ventilation, there's a high chance for long-term follow-up sequelae and long-term follow-up complications, unfortunately.
Klaus Rabe, pulmonary doctor. Thank you for sharing your insights.
Thank you very much for having me.
And staying with the experts, he's a biologist, a science journalist, and our resident corona expert, DW's Derrick Williams. And he's been answering many of the questions you sent us about the coronavirus pandemic. Here's our latest Q&A segment.
Can someone who has had COVID-19 catch it again?
There were some disquieting reports earlier this week from South Korea's Centers for Disease Control that 91 patients there who had COVID-19 and survived it tested positive again later for the disease. The WHO has also stated that it's unclear whether recovered patients are immune. That's critical because immunity is at the heart of strategies for combating the virus. The problem is that the body reacts to different pathogens in different ways, sometimes with a sustained immune response that lasts a lifetime, sometimes with one that lasts practically no time at all. So the answer to the question of whether or after how long you can be reinfected is we don't know yet. However, a couple of different studies have looked at how long the typical immune response lasts with related coronaviruses, ones that cause colds. And they show immune response there remains fairly robust after a year. And studies of how long SARS and MERS patients continue to produce defensive antibodies against those coronaviruses seem to back that estimate up. So what experts are hoping is that infection should provide some extent of immunity to most people for at least a year, but it'll take time to figure out.
Are people with allergies like hay fever at greater risk of contracting COVID-19?
This time of year is always tough on people with seasonal allergies in the Northern Hemisphere. I should know, I'm one of them. Hay fever causes inflammation in your respiratory tract. And though we don't know for sure, and I couldn't find any studies addressing this question directly, many experts appear to think that pre-existing inflammation might make it easier to catch the virus. I've seen a lot of recommendations from sources like national associations urging people to proactively try to keep their allergy symptoms as much under control as possible this year as a preventive measure. That's especially important, they say, if you have allergic asthma, because asthma is a comorbidity that's associated with worse outcomes in the event that you do catch COVID-19.
Can you reuse disposable masks if you leave them out for 3 days between wears?
This is a really tough question to answer because there's been so much debate surrounding not only the question of whether masks need to be worn by everyone, but also whether or not they can actually prove dangerous if they're not put on properly or handled correctly. Disposable masks are made to be disposed of after a single use, hence the name. The WHO continues to recommend disposal after a single use, but masks are in short supply during the pandemic, and even medical staff in many places are having to consider questions like whether they can be cleaned or reused. The Centers for Disease Control in the US recommends that when there simply aren't enough masks to go around, health workers only reuse them every 5 days and store the masks after use in breathable paper bags. Of course, that's for trained professionals acting in a crisis, but it's a guideline. Lacking others, it's what I would probably do myself, but it's really a suboptimal solution.